Over the past few decades, HIV has infected close to 36.7 million people, gaining international attention as an important global public health problem. HIV, or the human immunodeficiency virus, is an infectious disease that can eventually lead to AIDS, the acquired immunodeficiency disease, if left untreated. And treatment is the only option available to patients because HIV unfortunately does not have a cure. HIV's rapid spread and detrimental consequences that affect not only the individual but also the population as a whole is what has brought this global public health problem to the forefront of governmental health agendas around the world. HIV ultimately will affect countries' overall health status, economic growth, community dynamics, and ability to attain resources, so it is understandable that governments are attacking HIV head-on through efficient and effective treatment delivery. Currently, the most widely used HIV treatment is called antiretroviral therapy, or ART, which slows down the virus. However, ART is very expensive, making efficient HIV treatment delivery a challenge for governments. Many different aspects affect HIV treatment delivery efficiency, such as the type of healthcare system a government has, the development of new and current healthcare policies, cultural influences and outlooks, and the country's income level. As one can see, many different factors are involved in HIV treatment delivery, and each country will handle these factors differently. In this video, 3 countries will be examined for their approaches to HIV treatment delivery: the United States, the United Kingdom, and China. Although these countries may differ culturally and demographically, they are all faced with similar problems that they must address in order to deliver HIV treatment efficiently.
First stop, the United States of America. In 2013, 1.2 million people live with HIV, which is 0.4% of the total population. In the U.S., HIV is concentrated in 5 groups: MSN, African Americans, Hispanic, prisoners, and injection drug users. 2 forms of treatment delivery are utilized in the United States: treatment as prevention and ART. As of 2011, 37% of the HIV population in the United States was receiving ART. As prevention is utilized because in 2009, the CDC found that 91.5% of all new HIV infections were transmitted from people who are not in medical care. In response, the U.S. released guidelines titled Recommendations for HIV Prevention with Adults and Adolescents with HIV in the United States. These guidelines focus on early treatment, pre-exposure prophylactic, PrEP. Good private insurance makes one eligible for care, but if you're without insurance or underinsured, Medicaid, Medicare, or the Ryan White Comprehensive AIDS Resource Emergency Act care are options for funding treatment. Under the implementation of the Affordable Care Act, there is hope that with the expansion of Medicaid, more people living with HIV will have access to care. Second stop, the United Kingdom.
As of 2014, 103,700 people were living with HIV in the UK, which is 0.19% of the adult population. HIV infection rates are concentrated in certain at-risk communities, which include MSM, Black Africans, people who inject drugs, and heterosexual men and women. MSMs have the highest risk of HIV, with 1 out of 20 living with the virus. Of the Black African community, 55% of men and 62% of women are living with HIV. The UK has impressive treatment delivery rates, with 91% of the adult HIV-infected population receiving ART in 2014, which is a 7% increase from 2010. This high rate is largely due to the way the UK's healthcare infrastructure is organized. The UK follows the Beveridge model, where healthcare is provided by government-owned hospitals and clinics and financed through federal taxes. Under this model, the entire UK population has access to care, which is especially important for the HIV population since they would be ensured access to treatment. The effect that this model of healthcare has in terms of treatment delivery for key infected populations is illustrated by the fact that access among these populations is around 90%.
Last stop, China.
In China, there is a 0.5% prevalence, or about 780,000 people living with HIV/AIDS. Key groups include men who have sex with men, people who use injection drugs, and younger populations. 26% of MSM reported having sexual relations with a female in the past 6 months, meaning the disease is not well confined to these populations. There has been a 0.8% prevalence increase in the people aged 15 to 24 over a 4-year period, indicating growing impact on these younger generation.
Now we will compare each country to the United States of America. First, we have the United States versus China.
73% of all people living with HIV/AIDS in China are aged 20 to 39, whereas in the United States, 81% of new cases were confined to people aged 20 to 24. Of college-age subgroups, about 60% of the United States students reported sexual activity, compared to China, reporting just under 20%. Additionally, the same college-age students located in the United States scored a higher understanding of overall knowledge of HIV/AIDS, where China-based students had a more variable response. What these data suggest is that there are similar groups in both countries that are of great concern in regards to the disease. However, the 2 countries are not identical, and the differences in reported sexual activity rates may be representative of cultural or other differences, which would indicate a need for individually tailored methods. What can be determined is that there is still room for improvement between each country for the specific population, especially in terms of distributing reliable information. 91.5% of new HIV cases in the United States were transmitted from people not in medical care, including those unaware they were infected with HIV. In the US, 21% of people living with HIV/AIDS aged 15 to 24 are prescribed ART, whereas China has an ART rate of 63% of eligible patients. However, in order to receive ART in China, a specific CD4 count must be reached, which means a large proportion of patients are unable to get treatment. In both situations, the next step is pre-exposure prophylaxis, or PrEP, as preventing the disease is more effective and cost-efficient than any form of therapy.
Now we will compare the United States versus the United Kingdom.
From a study of Central and Western Europe and the United States, it was found that the US held 56% of all people living with HIV/AIDS, while the UK only held 5% of the total region. Some groups experiencing disparities are men who have sex with men, African Americans, people who use injection drugs, and transgender people. 40% of UK cases were considered late-stage diagnoses, resulting in 4/5 of all AIDS-related deaths in the UK. The large difference between proportion of people living with HIV/AIDS between the two countries can be partially explained by geographic and demographic differences. However, both countries appear to have similar groups experiencing healthcare disparities. What's more, both countries are very reactive and oftentimes struggle to respond with proper treatment in time. In the United States, a majority of HIV/AIDS funding was public due to the widespread use of safety net organizations such as clinics or emergency departments. In the UK, everyone is able to receive ART, but due to the distribution of infections, some hospitals and clinics quickly become saturated and are unable to dispense treatment when it is needed the most.
As it has been shown, even though countries such as the US, UK, and China may vary culturally, demographically, socioeconomically, policy-wise, and in terms of healthcare infrastructure, they are all faced with similar at-risk populations and challenges in regards to efficient HIV treatment delivery. However, although the challenges may be similar, the outcomes of HIV treatment delivery between these countries will vary, and these variances are largely determined by the attitude towards HIV and the type of healthcare system the country has in place. Analysis of the differences in outcomes of HIV treatment delivery can serve as a tool for understanding which approaches work most efficiently. These findings can formulate new policies and initiatives aimed at combating the spread of HIV and increasing accessibility to treatment. Therefore, the examination of different approaches for efficient and effective HIV treatment delivery should be stressed and encouraged, as it only serve to benefit the US, UK, and China's future endeavors against the spread of HIV.
Well, that's all, folks.
Created using Powtoon.